Ladies and gentlemen, we shall continue with our presentations now. In the first part of our meeting here this morning, we were all very grateful to Dr. Kafo for having brought us here in this splendid room, which is, I think, an apt place for the presentation of the papers that we are talking about. We have heard a great deal about the European perspectives and about problems, and as Dr. Mai said earlier, in the second part of our morning, we shall try to hear about some of the solutions that might be available. We have heard about the highly interesting model of Tuscany, and I think it was an apt illustration of the rule that has become more and more accepted of thinking globally but acting locally and creating locally relevant solutions to major problems that are contained in policies. In the second part of the morning, we shall have presentations that will put the earlier presentations a little bit to a test. The first of these presentations will be one that will discuss the issue of what are policies and what kind of policies do we need if we want them to be a veritable prescription for action that can be tested, that can be improved, that can be changed, that can be modulated and moderated. The second presentation will put the policies to a severe test because it will introduce the terrible but necessary economic component to our presentations of this morning and this afternoon, and Professor Martin Knapp will be introducing this. The third presentation finally will be like a brackets, the second part of the brackets to the morning's presentation. Professor Tsiantis will speak, but he will come back to some of the problems. He will come back to some of the problems that have been illustrated this morning and try to find out some of the solutions, as well as give a critical examination of the Green Paper and the efforts of the European Union. He is very well placed to do this, and I think not only because of his experience and participation in this work of the European Union, but also because he has been for so many years a key member of the European Union medical specialties. The first of our speakers will speak about policies. Dr. Richard Williams has been a child and adolescent psychiatrist for more than 30 years. He is also trained strategic leader and manager, a policy analyst and a policy maker. Since 1998, he has been Professor of Mental Health Strategies at the University of Glamorgan in Wales. This is a special post which combines clinical practice with policy making for Wales and England. It will be of interest to all of us to hear what he thinks about policies. Professor Williams, please.
There it is, it's back on. It's okay.
The problem, I think,
No, it's okay. Okay.
The problem is
Professor Sartorius, ladies and gentlemen, thank you very much for inviting me. I want to take you on a bit of a journey. My agenda is, in a sense, to prepare us for what I will characterize later as a constructive conversation in the policy for child and adolescent mental health. So I'm going to say what I mean later about what is a constructive conversation. But first, in order to get to it, I think we need to cover a number of other items. You may wonder what my title meant. I want to say something about what is the connected age. As Professor Sartorius has indicated, I shall say something about the nature of policy. And in particular, I want to focus on two sorts of policies: governance and governance policies, and strategic policies. In the course of this, I'm going to say something about operational policy, but only very briefly. What I want to offer you at the end is a composite model for policy. And my message will be that if we don't actually deal with the composite model, we are going to be in the arena that Matt Mugen suggested, of feeling frustrated that what we have tried to achieve appears to us not to happen. Of course, that is not so. If you look back over the last 50 years across Europe, child and adolescent mental health has advanced dramatically and enormously. And although Matt is right that there is still a huge paucity of knowledge, it's not knowledge that holds up the implementation of policy, or lack of it. It's lack of will. And the question is, how do we convert knowledge and the moral rectitude of our position into political will? So first, the connected age. Let me just summarise this in one slide. This is from a mathematician who became a sociologist and is now one of the world's leading students of the science of networks. And if we don't understand anything about networks, we won't understand terrorism. And if we don't understand networks, we can't understand healthcare. It isn't about structures, it's about how people communicate. So this is the proposition he starts off with. We are more connected than ever we were. The fact that we can hold a meeting like this in Florence shows just how connected Europe now is. But have we, on the basis of that huge connection, which has gone on for 2 decades or more now, and is accelerating day by day, have we resolved any of these problems? The answer is not yet. Let me say 2 things about this connected age. One of my passions at the moment is young people, children, young people, and disaster. And I'm working for both the Department of Health in England and NATO on this, and designing both a policy, a governance policy, and what I shall come to in a minute, a model of care. But it just seemed to me that what a research group published a few years back summarises what is the nub of the problem. Lack of consensus on goals, strategy, and best practice. And I think we could write that for child psychiatry across the board. We may say at meetings like this we have a consensus, but when we go home, we don't practice it. And there is no consensus between clinicians, policymakers, and strategic managers. And it's the strategic managers who are the missing link. We tend to assume that because we know what we know clinically, that we can gross that up to the governance policy level, and all should happen. But we leave out, at our peril, the strategic link that should operate in both directions. You see, as that paper about children and disaster said, the need for the interventions is not really disputed. It's the principles that should guide implementation are lacking. And there is a debate, a very big debate, which comes alive par excellence in the disaster scenario of 2 major schools. And in one of the early presentations where we were challenged about a medical model, not a medical model I recognise, and a social model, we saw in graphic detail portrayed the challenge, the diversity, the unresolved question about how we bring together evidence and values to come to a philosophy of care. We don't have an agreed philosophy of care. So if we don't have a philosophy of care, it's very difficult to link need, or however we conceptualize it, and very clearly, the woman who spoke earlier presented us with 2 different conceptualizations of need, and the strategies that we can implement in response. And so, at the close of this part of what I want to say, I'm sort of summarizing 40 years of network science in just a couple of slides. It's my job, I think, to tantalize you with this rather than to provide in-depth knowledge. You see, my key message is that as doctors, we don't look outside our own discipline enough. If we looked into the realms of sociology, of, as I say, this new network science, we might find some of the answers to some of our problems. So, why have we not solved our difficulties in communicating and being partners? All governments go around and urging us to be partners. And what happens as a result of that moral urging? Nothing. Because the implementation connection between governance and the values and what happens on the ground is absent. Let me move on then to types of policy and just tighten that a bit. It was a person called Black writing about this who really separated the term policy into three domains as regards healthcare. What he terms governance policies, and I'm going to come back in a bit to the Madrid framework for constructive conversations in the hope that we might perhaps decide to utilise something of that sort. And the second is what they call strategic policies, and I'm going to put at the centre of that having a model of care. And then there are operational policies. What we tend to do, if I say it again, is to look operationally at what is right and what is wrong with our services and try and magnify that into governance policies, leaving out the strategy. So let's just look a bit more at governance and governance policies. Here's a definition of governance. The processes whereby collective rules about attaining health gains, more effective health services, and fairer financial contributions are defined, drafted, negotiated, legitimised, adopted, and evaluated. So it's a complete process. Somehow in England we seem to have distorted this term governance to mean something that is about risk management. Not a whit of that here. The way we use this term, ill-advisedly, I think, in the UK, is to think about what organisations will not do rather than what they will. You see, we have to make a shift of thinking from the values and ethics of decision-making in conjunction with our patients about their individual healthcare to thinking about what are the values and ethics of how you do that very self-same thing with whole populations. And that is not lacking in complication. But what you see coming from governments is a wish for governability and order. And that overshadows the drive to establish new territory and to make history. This thing about order gets at the soul of politicians. And so we have bits of policy which in certainly the UK have spawned huge numbers of targets because they're interested in the outputs at the end of the equation. But what they haven't done is gone in the room and says, what were we trying to achieve in the first place? Let me give you two examples of some positive work that is being done. We're working on a plan for the UK for pandemic influenza, should that real nastiness ever happen. And I sit on this committee on the ethical aspects of pandemic influenza. And we've had to come up with an ethical framework for decision-making in very arduous circumstances about populations. And I've listed there some of the values that actually underpin that ethical framework. Similarly, in Wales, I've just completed writing an ethical framework for the commissioners who arguably are responsible for that strategy. Lack of strategy equals lack of commissioning in the UK model equals a gap. What we've started to do is to fill that gap, and we've started to write, or just written, about to publish, an ethical framework. So it is possible to deal with some of these things. I promised you, going back to the governance policies, a look at the Madrid framework. In 2003-2004, a group of policymakers became so upset from across Europe at a meeting very like this, became so upset with how the target culture seems to have taken over policy making and usurped it. In other words, we make policies on the basis of setting targets for bits of services rather than thinking about how we ordain the whole, that they sat down to think about how they could come up with a set of parameters upon which you could have a conversation about policy, and, in my view, additionally, come to some judgment about whether it's complete. So there are 11 dimensions in this, and I'll just run through them very quickly. The first dimension is to remember what we're here for. It's very interesting how rapidly, when you get into the arena of working with politicians, how rapidly you lose the goal, how process takes over from what we came to do. So we have to remind ourselves all the time that it's protection of health, which is our ultimate goal. We have to hold up our policies and ask, do they achieve enough in respect of equity? i.e., are they needs-led? And are they fair in a population sense? Choice isn't about choosing who to go and see at this level. It's about how we balance particular people against populations. If we decide to do X for a population and we're using all the money for that, how do we afford to do Y for one particular person in need? How do we make those choices? Arguably, it's on the basis of democracy that all the stakeholders should have a say in this. But to what extent do our policies actually create a framework in which all the stakeholders can have their say? Stewardship. There are 3 great responsibilities of government. Protecting the rule of law is one of them. But the Madrid Convention wanted to add a 4th to that 3, and that is protection of the public's health. In other words, to raise health to the same level as the rule of law. That means that they wanted to charge governments with the stewardship of health. And therefore the question is not just on how well do the individual clinicians perform, but how well do governments perform? How do they use evidence, and what evidence will they permit? Is it just high science, or are they going to look outside the arena of health science and take in evidence from other echelons? Is it efficient and accountable? Is there synergy? In other words, are the various departments that should be involved in taking forward policy? Time and time again in the UK, I come across bits of health policy, particularly mental health policy for young people, in which it's very clear that there is an insufficient synergy between policy for educating children and policy for their health care. If our policies don't deal with the lack of synergy, they are never going to get implemented. Or they'll get implemented in small arenas, but the big problems will never be tackled. We have to go in the room which says difficult, and we have to deal with difficult relationships. Is the policy capable of sustaining long-term service developments? Or are we caught forever in the longevity of governments, which generally tend to be short-term? How do we get a brave politician to sign up to something that goes beyond their span of office? Is the policy going to promote sustainability? And then there's interdependence. And this is both at a local, national and international level. And it includes dealing realistically with workforce planning and mobility across boundaries. Coming from the UK, how can I stand here and hold my head up when it's very clear that our government's policy on workforce planning about the medical workforce has been so horribly deficient in the last 18 months? That policy does not stand up, and therefore isn't a proper policy. Does our policy allow creativity? This is the final test. Because planning and delivering healthcare is not linear. In other words, most of our science assumes normal distributions. When Duncan Watts looked at the distribution of how we communicate, it isn't normally distributed. It's distributed according to power law graphs. And a lot of the commodities we study, we never look at the distribution. We assume it's linear, but it's not. If you assume it's not linear to start with, then that opens up the box that says creativity. And creativity, of course, includes promoting research, but research of a very diverse nature. Let me just come on to strategies. Strategic policies are those about handling the interface between bottom-up evidence of a variety of natures with top-down governance aspirations to produce a mix of evidence-informed and values-based policies. We can't have evidence-based policies because the evidence runs out far too quickly. And it would be unreliable if we did, because values abound. I heard Matt Mutual, I think at the beginning, say that we had to look to values, or that's the implication I took, because there were gaps in the science. Actually, the more science you have, the more decisions there are, and therefore the more we need values and clarity about them. So the strategic level that we often miss out is the place where some of the hard decisions are made. It's where the responsibilities for particular people meet the responsibilities for populations. In the UK, this is what we ask commissioners to do, but they rarely do. And therefore, we need an agreed model of care. Now, you won't be able to read that terribly well. I had some trouble with this slide overnight. But these next 3 slides contain what I've published in a paper are the constituents of a model of care. If we don't have a strategic model of care, we can't expect to see implementation of policy at the operational level. And this model of care is what is missing. In the UK, we have seen governments try to have a model of care, but it's been incomplete. They call it national service frameworks. That was an attempt at a model of care, but it's so incomplete as to actually not pass muster, in my view. So we have incomplete policies, we have incomplete models of care. I think we need to go back in the room and actually battle out some of these things. I think an organisation like this could come up with a model of mental health care. It means, critically, agreeing a philosophy of care. Not a restrictive philosophy, but a permissive one. But if we don't identify the philosophy of care, how are we going to combine the traditions of psychoanalysis with biological science? We can't just say we'll have them all. We've got to come up with a philosophy that allows us to do that and to put them in their place, and for what? Let me give you 2 examples of things that have to be solved. We have to decide what are the roles of child and adolescent mental health services. In Wales, we spent some time thinking about this, and we're very clear that child and adolescent mental health services are everybody's business. In other words, everybody works in child and adolescent mental health. My wife is a teacher. She has a more potent role in children's mental health than I do, because she sees more of them and has more opportunities to influence mental health. She is part of the child and adolescent mental health service in the UK, a very important part. We often use that term, child and adolescent mental health service, then, in a contracted form to mean those people who are designated as specialists. But if we don't look at the panoply of what we're trying to achieve, we will never achieve it. I have a big problem with terminology, you see. We talk about mental health problems. What on earth is a mental health problem? It depends on the time of day and who's defining it as to what's a mental health problem. So, is the role relief of distress? Is it relief of problems? Or is it relief of disorder? We have to be clear about who's doing what in this philosophy. Are we intervening with potential impacts on development which could have long-term consequences, as Matt asked us to think about? Are we thinking about preventing the mental disorder that those children might have when they grow up, interrupting cycles of ill health, disadvantage and deprivation then? And the second question is, who is included in our client group? Are we going to use diagnosis, the means of limiting what we do or don't do? Are we going to allow suffering at the other end? What does the woman's challenge mean to us about different models? And how are we going to deal with that? And the acid test of this comes at the strategic level, where we pass from the rhetoric of governments into the realities of having to put service on the ground. But it's at this level that I think there are the biggest gaps. So I'm going to pass through those, and you can pick me up about what's in this, and I'll refer you to the paper later on. Let me just say a thing about operational policies very briefly. In my view, we should be working to a mixture of evidence-informed and values-based operational policy, just as we use those same terms about strategic policy and governance policy. We need to be able to define at the operational level all of these things and a lot more. But I say to people, we can't have a care pathway unless we've got an agreed model of care. Unless we've agreed who is in the client group and what we're trying to do to them and what is the objective, how on earth could we have a care pathway? And yet I watch every day clinicians start laudably and well-intentioned with trying to draw up a care pathway which really describes what they do. And that's, of course, an important starting point. But if we want to alter it, we have to ask ourselves some more fundamental questions. So let's move towards this integrated framework. That is it, ladies and gentlemen. Down the left-hand side, we have the three types of policy, which I think we need to pick off separately. I know they overlap, and of course they should, because of course we wouldn't get implementation if they didn't. All three of them are led from values, principles, and evidence. And would it be nice if we could get all the people responsible for policies at those three levels to agree to use the same values and the same evidence? That is another challenge for a meeting like this. And perhaps if the declaration means anything, it means signing up to some of those core principles that we could sell at whatever level. Certainly, they are implicit in the Madrid framework. We could use the Madrid framework as a benchmark, a benchmarking tool against which we could evaluate what governments have done, where the gaps are, and where the gaps need to be filled. If we agree we need a strategic plan, should we base it on having explicit models of care for children and young people who have problems with their mental health at whatever level, whether it be distress or whether it be disorder at the other end of the spectrum? If we do have a model of care which is based on what is stated in our Madrid framework-based governance policies, it could lead on to models of practice and policies at the operational level that are informed from the top down and from the bottom up. What I'm suggesting to you, ladies and gentlemen, is that when we have our conversation this afternoon, could it be a constructive conversation in the terms that Marshall Marenka talks about in his excellent book based around the Madrid framework, in which we look at, and a bit more disciplined at looking at the difference between governance policy and operational policy, and trying to actually look at how we link the two together through strategy. What is it that we need to do at national and international levels to provide a template for governments on governance policies? What is it that we could do to help people with coming to an agreed model of care and going in the room and solving some of the very difficult problems rather than running onto the iceberg? Could we, as a group of people, begin to haggle out some of those complex things about philosophy of care? And can we base that not only on good clinical practice, but also on an agreed set of values, principles, and an agreed way in which we're going to use the evidence? For concluding comments, I go back to Duncan Watts. The world isn't a tidy place, characterised by random controlled trials. I can tell you that. I've just had an 18-month outing with a chest physician for my own healthcare problems. I am a single patient. He has got evidence about populations, but the populations didn't have my chest. That is the nub of the problem. We live in a messy world. It's ambiguous. What works for me might not have worked for the next patient and vice versa. We have to be the custodians of that as practitioners. And yet we also have to entertain the notion of trying to find some way of looking at these things at a population level and yet take some of those clinical realities with us. This is a conjoint effort. My suggestion is that if we have frameworks for policy and for models of care, we might make more progress. Thank you very much.